Good day. My name is Dr. Susan Dent. I'm a medical oncologist at Duke Cancer Institute and co-director of the Duke Cardio-Oncology program at Duke University in Durham, North Carolina. Today, I have the pleasure of talking to you on cardiac magnetic resonance in cardio-oncology, the oncology perspective. These are my disclosures. As oncologists in 2020, we have many challenges in the treatment of cancer patients. We are faced with an aging population that's at risk not only of developing cancer, but cardiovascular disease. We treat patients who have pre-existing cardiovascular risk factors, such as hypertension and diabetes. And we see patients that also come to us with pre-existing cardiovascular disease. In that setting, we then offer them therapies, cancer therapies that can be potentially cardiotoxic, such as anthracyclines, HER2 antibodies, such as trastuzumab and pertuzumab, immunotherapy, and a number of other targeted therapies. These patients are also exposed potentially to radiation therapy. And then, of course, unfortunately, some of our patients develop recurrent disease. So in this setting, not only are we tasked with trying to take care of their cancer, but trying to take care of their cancer in the setting of cardiovascular issues. Many of these issues may in fact leading us to stop cancer therapy or at least trying to modify it as we deal with their cardiovascular issues. So how can CMR help an oncologist? Well, as an oncologist, when we assess cardiovascular function, most often we order an echocardiogram. And when we do, we get back a number. And often that number may be borderline. And if it is, what does that mean? Does it mean I can proceed with chemotherapy or not? What happens when we see drops in LVEF? What does that mean in terms of continuing with therapy? What if we have people who have a difficult body habitus and the values may not be as accurate as we like? For patients with chest wall disease, how can we assess their cardiovascular function? And often we'll see that echo can be technically difficult. And how does that help us in terms of getting the information that we need to make a decision around cancer treatment? All of these things can lead to either us not proceeding with cancer therapy or early termination of cancer therapy that is potentially life-saving. And finally, how can MyoStrain help oncologists in clinical decision-making? This is a case of a 55-year-old postmenopausal woman with a recent diagnosis of lymph node positive ductal carcinoma of the left breast, who underwent a lumpectomy and sentinel lymph node biopsy. She was offered treatment with dose stents, and adriamycin and cyclophosphamide, followed by Taxol chemotherapy. Her past medical history was non-insulin dependent diabetes, obesity with a BMI of 40 and hypertension, and she is on metformin and carvedilol. She had a baseline echocardiogram ordered by the oncologist, which was difficult to do due to her body habitus, and the LVEF was estimated at 47 to 50%. So this is a real stop sign for oncologists. When we see anything below 50%, we get very concerned about proceeding with therapy. So our oncologist was concerned about this borderline heart function and referred her to our cardio-oncology clinic. In the cardio-oncology clinic, she had a CMR performed, which showed no anatomic abnormalities, mild LVH, and a normal EF of 54%. And as you can see at the bottom right-hand of this slide, a normal myohealth score indicating that in fact, the majority of her myocardial segments were demonstrating good LV function and that it would be safe to proceed with chemotherapy. So this demonstrates a case of where we may have either not given her the optimal therapy or at least reconsidered what therapy we're going to give her based on her original LVEF score. This is a case of a 47-year-old premenopausal woman who had a right lumpectomy and sentinel lymph node biopsy. She was shown to have a lymph node positive breast cancer, grade 3, ER/PR positive, HER2 negative. Her BMI was 30. She was a smoker, and her blood pressure was 140/90. She was on no medication. Her cancer treatment that was proposed was epirubicin, another anthracycline, for 4 cycles, followed by paclitaxel and carboplatin for 12, given weekly. She had a baseline echocardiogram with an estimated LVEF at 55%, and she proceeded with treatment. She went on to have, however, further imaging after 278 milligrams per meter squared of epirubicin, And we see her LVEF was 55%. However, her global longitudinal strain had decreased from minus 17.4 to minus 16. And so as an oncologist, I would ask myself, well, what does it mean to have a GLS score that's changed? And is this clinically significant? Will this affect my decision-making? So this represents actually her cardiovascular imaging throughout the course of her treatment. And as you can see, initially she had a normal LVEF, the picture on the left, of between 55 and 60%. But if we focus on the second diagram here, you will see that her LVEF did drop, but not substantially. More importantly, her MyoHealth score, which is reflective of the percentage of normal segments that are operating normally, is 62%, representing a significant drop from baseline, and more importantly, indicating to us that she's at risk of developing further cardiotoxicity related to this treatment. Of note is she did actually have BMPs performed, and it was high at the second time point. It was 181. And so this patient was started on metoprolol and candesartan, and then subsequently had further imaging performed, which showed a nice increase not only in her LVEF, but more importantly in her MyoHealth, going up to a score of 92%, indicating that now she had the majority of her segments were operating at normal capacity. So she was able to successfully complete her treatment with the cardioprotection, as I outlined previously. This is a case of a 59-year-old female with a recent diagnosis of Hodgkin's disease. She has type 2 diabetes and is currently on metformin. Our family history shows that her father had an MI in his 50s and her brother had a cabbage in his 40s. Her BMI is 55 and she's morbidly obese. Her proposed cancer treatment is doxorubicin at 35 milligrams per meter squared for 4 cycles, and her baseline LVEF is 65%. She proceeds with chemotherapy and has further cardiovascular imaging after 2 cycles of doxorubicin for a total dose of 70 milligrams per meter squared. And her LVEF is 58%. So it has dropped a little bit, and she notes some mild shortness of breath on exertion. So is this drop in LVEF clinically significant? So here's this patient showing her baseline imaging where her LVEF was actually pretty respectable by echo and by CMR at 65%. And her global longitudinal strain was also noted to be minus 22, which is normal. However, we look at her Myo strain and her MyoHealth score, 73%, and already you can see that she's starting to be at risk of developing cardiotoxicity. Her follow-up imaging after only 70 milligrams per meter squared of doxorubicin showed a significant drop in her MyoHealth score, with a 41% of those segments operating at a normal capacity, indicative of clinical cardiotoxicity. And so, although her LVEF had dropped by a few percentage points, I think this picture clearly shows you that she is getting into trouble with this treatment. And so it's not just the LVEF that's important here, but her overall MyoHealth. Her BMP was also noted to go up to 1,530. So in this case, this patient was started on ramipril. She continued on her treatment as planned. And you can see over the next subsequent imaging tests that her MyoHealth score increased up to 70%. And again, she was able to successfully complete her treatment as planned. And here's a case of a 47-year-old premenopausal woman with a recent diagnosis of a node-positive breast cancer who had a lumpectomy and sentinel lymph node biopsy, ER/PR positive, HER2 negative. She has a past medical history of multiple sclerosis, and her BMI is 19. The treatment plan is epirubicin at 90 milligrams per meter squared with cyclophosphamide for 4 cycles, followed by weekly Taxol for 12 weeks. Her baseline echocardiogram shows an LVEF of 54%. But because of her history and because of the MS, she does have a baseline CMR, which shows a normal LVEF of 55%, but interestingly, evidence of previous myocarditis. So, does the patient proceed with treatment given this history, and what is her cardiovascular risk during treatment? So here you can see her cardiovascular imaging starting from baseline. At baseline, we said she did have a normal LVEF of 55%, but as you can see here, her MyoHealth score is only 59%, indicative of that she is already getting into trouble prior to starting treatment, even though this is not reflected in the LVEF score, nor is it reflected in her echo GLS, which is minus 19.5. By her first imaging after starting her epirubicin after 270 milligrams per meter squared, her MyoHealth scores dropped to 54, showing that she is at risk of developing further cardiotoxicity. And so she is started on ramipril at 2.5 milligrams per day, and subsequent imaging shows that she has significant improvement in her MyoHealth score, and her LVEF stays consistent at 55%. So from an oncologist perspective, what I need to know is what are the best cardiovascular imaging tools to assess risk of my patients prior to initiation of cancer therapy? I need to also know what the best cardiovascular imaging tools are to assess risk during cancer treatment. And when should I consider cardioprotective strategies for cancer patients at risk of cardiotoxicity? And finally, what are the best imaging strategies for surveillance of cancer patients who develop cardiotoxicity? And I think this remains in large part an unanswered questions. The cases I've shown you today, I think clearly show that MyoStrain certainly may help oncologists in clinical decision-making. This is a certainly new technology that is now coming into the clinic, and hopefully as further information comes into practice, we'll be able to use this technology to help us make decisions around the delivery of cancer care safely to our patients. Thank you.